Thanks, organizers Sandeep D'Souza sir and entire team for giving me this opportunity to present this topic. So without wasting much time, let us start. So the topic for today is oligometastatic disease, definition and practice pattern. So the question that arises in my mind when I listen to this topic, does oligometastatic breast cancer deserve a dedicated treatment? Multidisciplinary management with curative intent, is it possible or is there any evidence? So let us go to the definition first. The ISMO says it is a low volume metastatic disease with limited number of and size of metastatic lesion up to 5 and not necessarily in the same organ, potentially amenable to the focal treatment aimed at achieving complete remission status. ABC3 says it is less than or equal to 5 meds. So the working definition here is limited burden disease that can be ablated completely. So the few points about oligometastatic disease, it is a 3 to 10% of all metastatic breast cancer. Oligometastatic breast cancers are rare, may have a curative potential. This patient can be identified through clinical features and maybe molecular parameters. And the biology of a oligometastatic disease cancer is not well understood, and adding radiation therapy in this setting may have added values. So just to have so what are different types of oligometastatic disease? There may be a synchronous oligometastatic disease that is present at the presentation, or oligorecurrence, that metachronous oligometastasis subsequent to definitive management. And it may be an intermediate stage between localized disease and overt metastasis. So let us first discuss one case. This was a real case which was present in our MDT. One 72-year-old female with ER strongly positive, PR strongly positive, and HER2 negative with the right breast lesion and sacral single lesion, which is biopsy proven. How to treat? That was a question. And what we discuss is whether the hormonal treatment with CDK4 inhibitor as a NSAID is correct approach or not. So let us go to different trials. Just I'm brushing through it very fast. These are various trials. So local regional treatment versus no treatment in primary tumor in metastatic breast cancer and open label randomized control trial. This is phase 3 systemic therapy plus early local therapy with systemic therapy, ECOG trial, ACRIN research group. Then this is a local regional therapy in de novo metastatic breast cancer, systemic review and meta-analysis. What is conclusion of these 4 randomized control trials with 970 patients? Local RT in metastatic breast cancer is not associated with improved OS. Results are consistent among different breast cancer subgroups. But now these all evidences are little previous trials. So do you have any retrospective trials? Here is example, effect of primary tumor excision in the breast cancer patient who present with stage 4 disease and intact primary tumor. There is a surgical removal of primary tumor, increases overall survival in patient with metastatic breast cancer. This is starting from 1988 to 2003 CR data. And does aggressive local therapy improve survival in metastatic breast cancer? So here we can see one more randomized trial with resection of primary tumor with no surgery, comparison is stage 4. And when you consider the entire data, there is evidence that longer follow-up study, median 40 months, shows statistically significant improvement in median survival. So what is oligometastatic breast cancer? Now he is like that monkey sitting, don't know what is to do. So this is in 1995 when it was Hellman and Wenchelbaum, they defined the term oligometastasis, and they first stated that it is a multi-step process rather than a binary phenomenon. Cancer full metastatic potential was not reached, and limiting it to certain sites only in the body that were receptive to cancer, implicating the seed and soil therapy. There is a clonal theory. Here we can see on this side the oligometastatic disease where the good primary tumor conditions and inhospitable target organ and the slug cancer cell that can lead to oligometastatic disease when compared to a poor primary tumor condition and hospitable target organ and actively migrating cancer cell leads to systemic disease. There is a concept of microRNA, that is a microRNA which is present in oligometastasis disease and polymetastasis disease are different. So it will help us to identify whom we choose as oligometastatic for local treatment. So what is guideline for oligometastatic disease? There is no guidelines. So everything is tailor-made. So this is a retrospective real world evidence. So 3,447 patients, January 2000 to 2007 were included. Detailed clinical history, therapy, outcome data were collected from medical records. Assessment of OS according to number of metastases at the diagnosis was done. And here what we see, 1 to 3 metastasis was associated with the favorable OS, and local therapy of metastasis was associated with a better OS. So here are a few trials with IGMRT trials, which is, you can see the outcome, which is quite significant when the radiation is given to oligometastasis. And stereotactic ablation radiotherapy versus standard of care palliative treatment in a patient with oligometastatic cancer. This is SABR COMET trial. And patient with a controlled primary tumors and 1 to 5 oligometastasis had a 13-month improvement in the overall survival and doubling of progression-free survival with SBRT versus standard of care was the conclusion. So let us go to the second case. So what has happened to the last case? We have started the combination of CDK4 inhibitors, that is letrozole plus palbociclib, and within 6 months there was a CR in bony met, and it was a partial response in the primary site. We operated that patient and put her on palbociclib, and 2 years are over and she's doing fine. We also radiated the local sacral site. So it has given a good response. So oligorecurrence, whether it is the same, here is a case, 54-year-old postmenopausal lady with IDC, ERPR positive, HER2 negative, P2N1, M0, DFI, 20 months. Then she developed a contralateral axillary node, clinically in biopsy positive. PET-CT contralateral axilla as the only site of metastasis. Is it a metastatic overt disease? This is oligorecurrence. Here is a review, contralateral lymph node recurrence in the breast cancer regional event rather than a distant metastatic disease, a systemic review of a literature. What it shows, OS 82.6% and disease-free survival of 65.2% at median follow-up of 50.3 months. Prognostic factor for resection of isolated pulmonary mets. So whether it is possible to resect that pulmonary metastasis or liver metastasis. First is this analysis for pulmonary metastasis, systemic review and meta-analysis, and surgery with relatively high 5-year OS rate after pulmonary metastatectomy, 46%. The main poor prognostic factors were DFI less than 3 years, resection of metastasis incomplete, number of pulmonary metastasis more than 1, and hormone receptor status of metastasis negative. So liver metastasis, is it possible to resect? It is, the data is very less, but resection of hepatic oligometastasis was initially motivated by an experienced resection of a limited volume hepatic metastasis from a colon cancer. An ability to preserve functional liver informs the choice of ablative therapy. Surgical resection for peripheral and large lesion, and while stereotactic body radiation, SBRT and radiofrequency ablation may be preferred for smaller central lesions. So let us come to the systemic therapy. So we are medical oncologists, more concerned about systemic. So what is benefit of systemic therapy as a NSCT? So there is some discussion and ongoing trial of ECOG, E2108 trial, and which includes stage 4 cancer who have not progressed during initial optimal systemic therapy to receive surgical resection followed by adjuvant radiation in case of breast conservation and adjuvant radiation following mastectomy. So this study is now close to accrual. 390 patients, ASCO 2020 demonstrate at a median follow-up of 59 months, no significant difference between this optimal systemic therapy plus loco-regional compared to systemic therapy alone for 3-year OS. But however, 3-year loco-regional recurrence and progression was significantly higher in systemic therapy alone now. So definitely there is a less loco-regional recurrence when you use systemic therapy and SCT. And the final results are still awaited. We are eagerly waiting whether it gives a definite OS advantage to us or not. So do advances in systemic therapy changes MDT in OMBC? Means addition of some additional pertuzumab, CDK4/6 inhibitors and PI3K inhibitors. Definitely, this is a topic which can be discussed. Here is a recent Cleopatra trial study changed the standard pattern with addition of pertuzumab that we are aware. Can we extrapolate that thing? Also, I have discussed a case with a palbociclib was given as a NSAT That is an example that this change, advances in systemic therapy, is definitely going to change MDT in OMBC. What about immunotherapy in OMBC? Deshmukh sir is going to discuss about the immunotherapy, but we were discussing just before that I was having a patient who was triple negative oligometastatic breast cancer, and I discussed with one of their relative in US, and they were suggesting that to add immunotherapy pembrolizumab to the chemotherapy NSAID arm. Unfortunately, because of the cost, we could not have added. But that patient, after extensively strong NSAID surgery and capacitapine maintenance, recurred early. So that was a question whether pembrolizumab would have benefited that patient. So definitely triple negative is different disease than an ERPR positive and HER2 positive. And ERPR and HER2 give a better result that we are aware. So which patients to be treated? So there is a specific set of patients, they will give a benefit if you treated with a local treatment, that is a bony metastasis, ER positive or even PR positive with all targeted, and less than 3 metastasis. So this is, and the last point here is role of microRNA in OMBC. Why microRNA is important? For better patient selection for metastasis directed therapy. Here is the abstract which shows that they have a results. Patients who fail to develop polymetastasis are characterized by unique prioritized feature of microRNA classifier that includes the microRNA 200 family. We created an oligometastatic polymetastatic xenograft model in which patient-derived microRNA discriminated between two metastatic outcomes. MicroRNA 200 enhances in an oligometastatic cell line resulted in polymetastatic progression. And conclusion what they draw from here is this result demonstrate biological basis for oligometastasis and a potential for using microRNA expression to identify patients most likely to remain oligometastatic after metastatic directed treatment. So definitely there is a role of microRNA to identify correct group of patients which will get benefit from a local treatment in oligometastatic breast cancer in the future. So what is the take-home message from today's discussion? Oligometastasis is completely different entity from disseminated metastatic breast cancer. Offer patient tailored treatment for oligometastatic breast cancer. Curative intent treatment should be aimed toward primary as well as oligometastasis. Good results obtained when less than or equal to 3 metastasis. Young good performance status. Also ERPR positive status and bone only mets. Thank you very much.
Thank you, Dr. Kshitij.